We'll look at some of the technical aspects of performing the examination, the current indications for breast sonography. Then we'll look at some normal and abnormal sonograms. Recently, in an attempt to standardize the performance of breast ultrasound, since it's now an accepted part of a breast imaging practice, the AIUM and the American College of Radiology Breast Task Force have developed guidelines for the performance of ultrasonography. And I think this is an important step forward, since there is a variety of ways it's practiced, and many practitioners are looking for advice and guidance. First of all, of course, it should always be done in terms of equipment, with real-time equipment and a high-resolution scanner. It should, when the resolution is variable, it should be done at the highest possible resolution that allows adequate penetration of the breast. You're probably all aware that the breast is one of those organs that attenuates ultrasound very rapidly due to the multiple interfaces and the shape of the interfaces, which are primarily round. So much of the sound is reflected away from the transducer. So penetration can be difficult. But nonetheless, it should usually be performed at 7.5 to 10 megahertz. However, occasionally 5 megahertz is required for penetration of the dense or thick breast. In terms of the documentation of the images, according to the AIUM guidelines, which are consistent with the ACR guidelines from the Breast Task Force, each exam should include the examination date, patient's name and ID number, the image orientation, and the anatomic location based on a clock face and possibly a diagram. The clock face, of course, is different for the right and left breast. In addition, the recommendation is that each examination should contain the sonologist's ID, whether it be technologist performing the examination or radiologist. In terms of retention of the ultrasound examination, the same guidelines hold that are for mammography. It should be consistent with mammography guidelines. We wouldn't want to discard the ultrasound any sooner than the mammogram. And it should never be less than 60 months or 5 years. So all mammograms should be kept at least 5 years, and that's the minimum, and the sonograms should be kept at least as long as the mammograms. In terms of the variations from that, it should be based on facility requirements as well. However, it should never be less than 60 months. Facilities may have different requirements. As long as they're not less than the AIUM and ACR guidelines, that would be fine. Now, in terms of the indications for sonography today, we should start by saying that it's not a screening study, although some radiologists are still using it as a screening study. There's absolutely no evidence that this is effective, and it may actually be detrimental, either by giving a false sense of security or leading to unnecessary biopsies. What it is in the breast, a directed examination to characterize a lesion that is either palpable or found on mammography. It is also an excellent method to guide interventional procedures, largely because it's done with real time. And for core biopsy or fine needle aspiration of the breast, many prefer sonography, and most who do core biopsy or needle biopsy to any degree will use both X-ray guidance and sonogram guidance, and they'll vary that according to the case, whichever is best suited for that particular case. It can also be used for other interventional procedures, which we'll talk about in a minute. It's also been used to evaluate implants, particularly silicone implants in the breast. Normally, the tissues of the breast are either sonolucent, like fat, echogenic and sonolucent, or they have higher echogenicity, and that's usually the parenchymal tissue in the normal breast. A little bit different than some of the other organs in the body where fat has high echogenicity. In the breast, compared to the parenchymal structures, the fat of the breast is relatively sonolucent. Now these are from whole breast scanning, and the only reason I'm showing them is because they're an excellent way to look at the anatomy. But today, we really are not doing whole breast sonography because the only purpose of whole breast sonography was to do screening. Today we do directed ultrasound. In fact, we don't want to have information usually outside of the area of clinical interest. Now there are two types of tissue on sonography. There's the tissue you see in the fatty breast, so that gives a different sonographic appearance, and the tissue we see in the dense breast, which gives, again, quite a contrast in terms of the way it looks on sonography. That's because there's more fat in the fatty breast or the older breast often. Sometimes it's an older woman, sometimes it's not, but frequently is. And that's because the fat is relatively sonolucent compared to the dense parenchymal tissue. So on mammography, this would be the whiter, dense part, and the fat would be grayer or darker. And on ultrasound, it's more sonolucent in the fat, and it's more echogenic in the dense tissue. And of course, there's a sharp interface between the mammary tissue and the pectoral muscle, which is shown here. And you've all seen that the ribs can mimic lesions. They should lie below the pectoral muscle in most of the breast, and they also have shadowing behind them, and they're sonolucent or anechoic. In the denser, and also we can see ligaments in the breast which can cause refraction of the beam, but or shadowing behind the ligaments. But these also can be seen very well on sonography, particularly in the breast with a lot of fat in it. Now, in terms of the denser breast, it's almost primarily echogenic, and you can see that a lesion in here that had different echogenicity would show up very easily. In the fatty breast, it's more problematic with ultrasound because fat lobules can mimic lesions. And here's an example of the typical fat lobule in the breast that more than once has been biopsied when it was found on sonography in a woman who had a mammographic finding or maybe a questionable palpable finding. Usually we don't have too much trouble with this because of the typical echogenicity. It should match the subcutaneous fat. And usually if you scan along the margins, you'll find another lobule of fat adjacent to it. The primary use of breast sonography is to characterize masses, and this characterization will depend on technical factors, so experience is required. It is very important that the focal zone be at the depth of the lesion, and gain and power settings can affect the diagnosis of cyst versus solid lesions. Within the first 1.5 centimeters of the skin in the subcutaneous tissue, a fluid offset is often required if the transducer doesn't have an adequate fluid offset already, and that's readily identified when you begin to use the unit. In characterizing masses, again, it's important to identify laterality, clock face, and orientation. And there should be at least 2 sets of images of the abnormality, of the lesion. One should be with calipers and one without, so that it doesn't disturb the appearance of the lesion, and it should be measured in 2 directions. So these are the guidelines that have been put together by experts as a consensus. In terms of the overall management of the woman, when we find a mammographically circumscribed mass in the breast, that's when sonography is most important in the mammographic workup as an adjunct. If circumscribed masses are multiple, we do routine follow-up. We do not go to sonography because multiple circumscribed masses are benign. Doing sonography usually will either confirm that they're cysts or will show that they're solid, but it doesn't matter because if there are multiple solid circumscribed masses, they also follow the rule of multiplicity in that they will be benign. And doing ultrasound just adds expense to the workup, anxiety for the woman, and it may lead to an unnecessary biopsy because if you find a solid mass, report a solid mass, often these women end up with a biopsy. However, if the circumscribed mass is solitary, then mammography may show that it's definitely benign, which requires no workup, or, and that would be cases that Dr. Dershaw mentioned, which would be those that contain fat, those that have typical calcifications. If it's uncertain as to what the nature of the mass is, it should go to ultrasound. And the sonogram should show either a simple cyst, a complex cyst, or a solid mass. If it is a simple cyst, then the woman goes into routine follow-up. Occasionally, we will do an aspiration of the cyst if it's particularly tender or bothersome to the woman because it's palpable. But usually, a simple cyst means routine follow-up with no need for further intervention. Cysts are the most frequent masses in women 35 to 50. And if they are 5 millimeters or more, you should be able to see them on the ultrasound unit. Cysts will show up in the breast because, as we've seen, the breast is composed of echogenic material. So an anechoic mass within the breast should stand out. Its contrast from the surrounding tissue should be very high. So we can see very small cysts. We can't see solid masses always that are this small. The accuracy for cyst diagnosis is about 98%, which is very high, of course. And they're characterized by anechoic interior and enhanced distal echoes. Two typical cysts are shown here. This is the more typical one that's round or oval. It has a sharp posterior margin, enhanced through transmission, lateral edge refraction, but most importantly, an anechoic interior. Septated cysts are common and are usually not a problem. A linear septa within the cyst, as long as the rest of the cyst is anechoic, shouldn't lead to a differential diagnostic problem. We would call this a septated cyst, and unless there was clinical signs of an abscess or something else that would lead us to do further workup, this again would go into routine follow-up. Often when we see a lesion this small, we think, well, why even do an ultrasound? It's too small. But in fact, again, it should show up because it's 5 millimeters, and here it is within the surrounding echogenic tissue. It shows up because of its contrast from the surrounding tissues. If that lesion did not show up, our general assumption is that it's solid. Not all cysts are easily identified as anechoic. And this can be due to technical factors such as the power or gain being too high. And therefore the power should be as low as possible to penetrate to the chest wall in most women with compression with the transducer, but high enough to see internal echoes if they're present, and this requires some experience. This is a normal or routine examination of a cyst, and you can see that there are some anterior echoes. These are normal reverberation artifacts with this particular gain setting. As we increase the gain, the echoes begin to increase. In a cyst, they'll usually increase around the margin rather than in the center. And in this case, we changed from a just for demonstration purposes to a logarithmic grayscale to show that too will increase the appearance of echoes within a cyst. So it does require careful examination and experience to determine whether it's cyst or solid, but this can be learned very rapidly. This is a case where there's no fluid offset on this transducer, and this is a cyst that's very close to the surface in the subcutaneous tissue, within 1.5 centimeters of the skin. You can see that it looks like there's echoes in here. With a fluid offset, those are gone, and we can see that this is a normal cyst. So lesions near the surface, we have to be careful about them because of their position relative to the focal zone. Now, if we get a complex cyst rather than a simple cyst, then we have to be concerned that we may be dealing with an abscess, intracystic carcinoma, or cavitating carcinoma, and we want to prove that that is, we want to work that out before letting the woman go. So in that case, we will usually do aspiration of the cyst and often pneumocystography. By the complex mass, I mean one that has fluid inside, but it also has solid elements that are not definitely a septum. This is an example of a round, relatively circumscribed mass that was palpable. And on sonography, yes, there was areas with fluid that were anechoic, but in addition, there were echogenic areas that looked like they could be in the wall of the cyst. This raises our suspicion that we're dealing with a papilloma or even intracystic carcinoma, which is very rare, but nonetheless can be found, particularly if the lesion is palpable, and that was an intracystic carcinoma. This case, another round lesion, which was palpable. And the sonogram shows, yes, there's fluid inside and it's anechoic, but in addition, the wall is very thick. It looks somewhat irregular on sonography. The posterior wall looks irregular. And because of this thick wall, that was aspirated. And air was injected. And in a normal cyst, the injected air will show a very sharp, smooth lining that should fill up the whole mass. It should completely fill up the cyst, the area of the cyst. In this case, the air is inside, and you can see it does not fill up the cyst. There's a very thick wall, and here there are some undulations in the wall of this complex cyst. Blood was aspirated, and at biopsy, this was a medullary carcinoma with cavitation. In our experience, it's more common to find a cavitating carcinoma presenting as a complex cyst than an intracystic carcinoma. Then the ultrasound may show that the circumscribed mass is solid. And if we're not certain about the margins, we may want to do spot compression magnification after the sonogram. And if the margins are circumscribed, we may just want to put the woman into follow-up or do a biopsy according to size, other clinical features, and our experience. And the decision about what to do with these cases is still being worked out in terms of evidence in the literature. Dr. Sickles has written a paper about it, and there will undoubtedly be others, because this particular track of the algorithm still needs to be worked out more carefully, but there are guidelines in various practices, and for most cases, if it's a very small circumscribed mass, we would follow it. If it, however, is ill-defined on the magnification spot compression views, we'd go on to biopsy, and that would usually be a core biopsy. Some examples of solid masses are this oval-shaped, elongated mass along the plane of the breast that has homogeneous, even echoes inside of it, sharp margins. This one has diminished posterior echoes. This is a fairly typical fibroadenoma in the right age group, in clinical setting. This is very typical. Sometimes we do core biopsy, sometimes we don't. It depends on the clinical setting and the surgeon's preferences and a lot of other things. But it's fairly typical fibroadenoma. This one, on the other hand, is round rather than oval and oblong. It's irregular in its margin, including posterior margins. It has distal echo attenuation as well. And this is a very suspicious mass. It's got irregular echoes inside. And this is often what we see with a carcinoma on sonography. We can't make the diagnosis based on the sonogram alone, but we certainly would want to biopsy this lesion. And it was biopsied and was an infiltrating carcinoma. The distal echoes are not of great help in determining whether a lesion is benign or malignant. Although carcinomas often shadow, in our series of cases where we looked at 45 consecutive carcinomas examined with ultrasound, 1/3 of them had enhanced through transmission distally. So technical factors and a lot of other things come into play, and enhanced through transmission does not mean that we're not dealing with a carcinoma. But just to emphasize that sonography cannot always differentiate benign from malignant solid masses. There's this case where this circumscribed mass had increased in size slightly. It was now 8 millimeters. On the exam that was done 6 months before, it was 5 millimeters. The sonogram was then done and showed that it was relatively circumscribed posteriorly. It was round, had even echoes, and enhanced through transmission, but at biopsy was a carcinoma. So we have to remember that solid masses can't be histologically classified by sonography. One of the most important uses of sonography today is to guide procedures. It's becoming more and more commonly used because as we get more adept at using it, we find it's faster sometimes than stereotactic guided lesions. Sometimes it's more accessible. Lesions are more accessible sometimes on sonography. The different procedures that sonography can guide are cyst aspiration, wire localization, needle biopsy, and it can be done either freehand or with a needle guide. Needle guides are available, and usually this is a personal preference or based on experience. And often when we do a biopsy, we want to show that the needle is within the lesion, and that's one of the benefits of sonographic guidance. It can be done with real time, so that there wouldn't be any question but that this particular specimen came from within the lesion. And we do that in 2 directions. Another use that we found for sonography is the evaluation of implants. Silicone implants. Many women come for silicone with problems associated with their silicone implants or symptoms, referred to as by plastic surgeons or other clinicians. And we've learned that there are certain findings that are associated with an intact or ruptured implant. And many of these here are from the literature. An intact implant should have continuity of the implant shell. It should have an anechoic interior. It may show anterior reverberations. This is not abnormal. And may show radial folds, which is folds in the implant shell that show up on the imaging study. On the other hand, a ruptured implant will often show discontinuity of the implant shell, according to the literature. May have heterogeneous aggregates of echoes within the implant rather than an anechoic interior. It may show echogenic noise, which means there's a disruption in the normal echogenic pattern. Or it may show what we call a Linguini sign or stepladder sign, which is a floating membrane within the implant. Let me just show you what some of those normals look like. This is a normal implant at sonography. This is the normal tissue anterior to the implant. Here's fat and fibroglandular tissue. And here's the very sharp implant shell, the border of it, or the fibrous capsule. and the implant shell below it, and here's the anechoic interior, which is normal. Again, a fluid offset may be necessary to see any abnormalities anterior to the implant because of the fact that these will be very superficial. A radial fold is shown here. These are normal. Goes all the way across, and on many studies these are frequently encountered. This too is a normal one in that this is the normal tissue anterior to the implant, and this is reverberation artifact that's very homogeneous in the anterior aspect of the implant. In our experience, never thicker than the anterior tissue, and below it the anechoic interior. Now, there are two types of rupture that can occur, and I want to explain what they are before showing the findings because it's important to understand them. If this blue line represents the breast, this red line would represent the fibrous capsule that always forms around an implant when it's placed in the breast. It's the woman's own fibrous tissue reaction, and it usually forms an intact capsule around the implant. This black line on the periphery of the white silicone gel is the implant shell. If the implant shell ruptures, but the fibrous capsule is intact, the silicone will be retained within the fibrous capsule, and the membrane will begin to collapse, forming this spiral-like structure, which is different chemical composition than the rest of the silicone, and it will show up on an ultrasound examination or on a magnetic resonance imaging exam. In extracapsular rupture, in addition to the membrane being ruptured, the fibrous capsule is always also ruptured, so the silicone not only leaves the membrane but may leave the confines of the capsule and travel to other parts of the breast, as in this case. And on sonography, the intracapsular ruptures are seen as with horizontal lines representing the floating membrane and heterogeneous echoes. Those are reported to be two major findings. Extracapsular shows echogenic echoes in the nodules in the surrounding tissue, pretty easily identified. Here's an example of the stepladder of the floating membrane inside the ruptured implant shell, the implant shell floating within the silicone gel. And this one was an intracapsular rupture with an intact fibrous capsule. And here's another patient. You can see that this is a continuous line, and it is just the floating membrane floating inside the silicone gel. And this is a case of heterogeneous aggregates. Another reported finding, which we didn't find, is as consistent in cases that we reported. We recently reported 20 cases of ruptured implants, and we looked at all of the signs in the literature that are found, and we found that the most common thing to see was reverberation, which can also be seen in a normal. The stepladder sign we found was the next most common finding. It was the most consistent evidence of ruptured implant. Heterogeneous aggregates were only found in about 5 of these cases, so this was not a very good sign in our experience for implant rupture, and the other signs were very rarely seen. The overall sensitivity for ultrasound and implant evaluation is 70%. Specificity is 91%, which is pretty high. Because of the lower sensitivity, we consider it a screening test. If it's negative and the woman still has symptoms, we'll recommend MR imaging since it's now about 95% sensitive to implant rupture. So in summary, we've looked at some of the technical aspects of sonography, the indications for this examination according to new appropriateness guidelines. We've looked at normal and abnormal ultrasound of the breast, and we've seen how it works as a tool in the evaluation of a symptomatic woman with a problem with silicone implants. Thank you very much.